Assuming anaesthesia in critical care, we will cover the key topics surrounding fetal circulation. Firstly, the differences with the adult circulation, we'll describe the fetal circulation, and finally cover the transition at birth. The fetal circulation has three unique characteristics. Firstly, the presence of shunts, the foramen ovale, the ductus arteriosum, and the ductus venosum. Due to the low intrauterine oxygen tension compared to extrauterine life, the fetus increases the oxygen contents to compensate for lower partial pressure. This is achieved by increasing the haemoglobin, by the presence of fetal haemoglobin, which shifts the oxygen dissociation curve to the left, and finally the presence of a high resistance respiratory circulation. This graph compares oxygen content in mils per litre compared to the partial pressure of oxygen in kilopascals on the x-axis. As shown, due to the increased haemoglobin, this results in a high oxygen content for a given PaO2. This diagram has two key discussion points. Firstly, the fetal circulation with the associated oxygen saturations, and secondly, the transition circulation during birth. It's important to point out that the fetal venous system has a high oxygen saturation than the arterial system, and the cord contains two umbilical arteries and one umbilical vein. Oxygenated maternal blood crosses the placenta. The placenta is connected to the fetus by the umbilical cord, which contains one vein and two arteries. The vein has two branches, left and right branch. The right umbilical vein supplies the liver by the portal sinus, and the left umbilical vein branches into the ductus venosus and thus bypasses the liver via the IVC. The IVC oxygen saturations are lower than 80% as seen in the umbilical vein due to oxygen consumption in the liver. As blood moves from the IVC to the right atrium, the blood becomes shunted across the atria via the foramen ovale to the left atrium, and this is mainly due to the high pulmonary vascular resistance due to relative hypoxia, hypercapnia and acidosis within the fetus. Blood then moves from the LA to the LV to the aorta. It's important to point out that some blood will enter the pulmonary circulation despite this high pulmonary vascular resistance. However, due to the ductus arteriosus, it will move down a pressure gradient into the aorta. As we move down the aorta, it will subsequently bifurcate into the internal and external iliac arteries. Each external iliac artery produces an umbilical artery, which moves back to the placenta. Now we'll discuss the transition at birth. At birth, the baby takes its first breath. This results in lung expansion and a higher partial pressure of oxygen in the alveoli. This results in pulmonary vasodilation, reduced RV pressure, and increased LA pressure as blood flow returns to the left side of the heart, leading to closure of the foramen ovale by the lungs. The decreased pulmonary pressure results in a reverse in the pressure flow across the ductus arteriosus. Therefore, blood moves from the aorta to the pulmonary artery. Once the cord is clamped, you get reduced flow through the umbilical veins. This leads to reduced flow through the ductus venosus and thus reduced venous return to the right side of the heart. Now we can look at the functional and anatomical changes of these shunts over time. The first one to close is the foramen ovale, which will become the fossa ovalis. The closure is initially due to an increase in LA pressure and subsequently fibrosis, which can take up to 12 months. Next is the ductus venosus, which becomes the ligamentum venosum, which initially closes due to reduced flow down the umbilical veins and subsequently fibrosis, which can take up to 3 months. And finally, it's the ductus arteriosus, which becomes the ligamentum arteriosum. As discussed, after birth, there's a reverse in the flow down the DA from the aorta to the pulmonary artery due to changes in the pressure gradient. There's also an increase in oxygen tension, which results in inhibition of ductal smooth voltage dependent potassium channels, resulting in constriction. And finally, PgE2 and PgI2 levels fall because of metabolism in the lungs and elimination from the placental source. However, as time progresses, fibrosis will ensue, enabling permanent closure, which can take up to 3 weeks. Thank you for watching and listening.